Alrighty. Good afternoon, everybody. Welcome to SEVA VentRounds. Today is July 11, 2023. And the topic for today is a little bit of respiratory rate and when a simple setting goes wrong. And we'll talk a fair amount about this. The disclosures is we will discuss particulars of ventilator modes. There is no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinics. The hosts are Eduardo Mireles and Rob Chatburn, and we do get some fees and royalties for other things not, related to mechanical ventilation, but if you should have no evidence of bias while we're talking about what we're talking today here. There are some ground rules. This is a live session, so and it's recorded. If put on the chat that you want to say a statement, we're happy to hear you. Or if you want to put just on the chat your thoughts, we're happy to highlight them. That's how this works. It's an open forum. And so then we will call on you to comment and discuss. If you want to use, use the chat function on your WebEx. There are CMEs for CCF employees and CRCEs for all the RTs, wherever you are and you want to get engaged on. Please enter, if you're a RT, enter your name on the chat to verify the attendance. And then at the end of this hour rounds, we'll put in a link for you to complete an evaluation. So as always, we start with a brief nugget. And here, Rob and I will talk a little bit about setting the respiratory rate and what it means. And I think that in general, as we're setting the ventilator respiratory rate, I think of two ways for the respiratory rate. If I'm not trying to, the patient is breathing spontaneously, then I set a lower value at the minimum that I think that the gas exchange is tolerant, lowest possible pH that I would be comfortable with. And then if you have somebody which you have to increase or the respiratory rate, we usually set the higher value at the value in which you have the least amount of autopip, or that's part of the thought. Although we have done work on this area, but that's how it's usually set. Now the lower value, for whatever reason, usually tends to be on the higher side rather than on the higher side, and this will help you work through it. And then there's a little myth that I hear now and then, which is trying to match the rate on the ventilator to the patient's rate, like if that was going to decrease the work of breathing of the patient. So Rob, I thought that it would be useful for us to talk a little bit about the Otis graph. If you want to explain to us what we're seeing here.
Sure, just briefly, back in the 50s, Otis, Span, and Ron and Mead were studying respiratory patterns of normal patients and normal breathing patterns. And what they discovered was that there is a relationship between frequency and the rate of work, which is power that the body actually has to expend to get whatever level of minute ventilation is required for adequate blood gases. And what this shows is basically is that somehow the brain, the body knows that there is an optimum value of frequency, and of course tidal volume would be optimum if you take that frequency and divide it into the minute ventilation. So what these graphs, these curves show all the same minute ventilation, but different combinations of frequency and tidal volume and the resulting power that comes. So this shows that in this particular case, for a normal patient with normal resistance and compliance, the breathing frequency is about 15 breaths per minute, as we all know. And it just turns out that that is the lowest caloric expenditure and the least power generated by the ventilatory muscles. Now, these curves will shift depending on the lung mechanics. So they'll shift to the right as the lungs get stiffer, and they'll shift to the left as the resistance goes up. So in other words, if you have a small time constant, you'll go shift to the right. And if you have a long time constant, you'll shift to the left.
Thank you, Roberto. I think that your screen is free, your connection is unstable. So if you want to turn off your camera, that may help to maintain you.
You were
So let's
breaking up on my
take a
audio.
look. Yeah, that's better. Yeah, you were breaking up.
Okay, got it.
All righty. So let's take a look at this case, which for which the respiratory rate may or may not be engaged. So this was Ariel got this from one of our patients here at in our ICU, and it has created a lot of noise. So let's get started with it. Really interesting situation. So as usual, we start with the tag, and I have the chat open. And if you want to start by writing on the chat what you think the tag is, and I see some of the team members are starting to put it in. And the goal, I mean, obviously the name of the mode is up here, and that is important. It helps you, but the tag is what actually the mode does. And so rapidly, I can see that there's congruency on the chat regarding what the tag is, and what it's talking about is that this is a pressure controlled. So during inspiration, we're controlling pressure on the mode, and then the breath sequence is CMB, which means that every breath is mandatory, and mandatory meaning that it's either triggered by the machine, like this breath over here, or cycled by the machine, either or. If any of those variables is controlled, it becomes a mandatory breath. So in all these breaths that we have a high amount of, they are all mandatory breaths. And then finally, S for set point, which stands for the targeting scheme, which is how the computer controls, the ventilator controls, the computer controls the ventilator, and essentially we set the inspiratory pressure and the PEEP, and that's what the machine is, and the inspiratory time. Rob, any comments on the tag?
Nope, straightforward.
Straightforward, high quality, very nice. Now, the next thing is to determine by looking at, and this is relevant when you're looking at patient-ventilator interaction, is what's the load? Is it an elastic load? Is it a resistive load? Or we're seeing a lot of PMOS? So I see some back and forth coming in. So put your thoughts. What do you think is going on? Is it resistive, elastic, and PMOS? And as we have discussed in many times, sometimes you're looking at the waveforms and you can see through it some amount of resistance, even though there's PMOS. So you please comment without fear. Safe space. All right, I'm starting to see some comments come in. So as we look at the remember, that's why we put always the tag. So if we are controlling pressure, then we look at the flow during inspiration, and we know that during expiration, we look always at the flow. So during inspiration, I will point out a couple of items. The first one is if you look at, and I'm gonna number them here just for the sake of our understanding and that we're all aligned. I'm gonna put just numbers to each one of these breaths. So you have 1, 2, 3, 4, 5 mechanical inspirations during this event. And if you look at the flow of breath 1, breath 3, and breath 5, in which there's actually flow, in breath 2 and breath 4, there's minimal flow. You can see that they're all different. And so there's some differences there that are telling us that there's a presence of PMOS. That usually, if there was no PMOS, you would expect all of them to be pretty similar. So that tells me that there's PMOS at least more on breath number 3. But if you notice breath number 1, it is taking a fair amount of time for it to decay. And although there may be some PMOS, and I suspect that there's PMOS, that's a hint that there may be an increased resistive load. So the next thing that I go to look at is the expiratory phase. And when you look at the expiratory phase, again, you see some amputation of the expiratory flow. So instead of looking nicely like that, it's missing the peak. But you can see the next one has a nice peak. And it takes a fair amount that there's exponential decay, and it keeps going, and nothing happens. And this can be expiratory muscle, but it's also a feature that may highlight that this patient has a very high resistance during inspiration and expiration. And I would probably suspect, actually, from the next waveform that you see here, and we'll talk about that there's probably activation of the expiratory muscle.
Yeah, going back to number one, you said that
Yeah.
slow rate of decay of flow is questionable. It could either be a large inspiratory effort or a high resistance. And I would favor
Yes.
a high inspiratory effort over resistance, because you notice the peak flow is quite high for a relatively low peak pressure. So peak flow, the initial flow, is always going to be the delta P, which is peak minus peep, which is what's the peep 10? So that's only 13 divided by resistance. So you get a very high, you get almost like 60 liters a minute. So I wouldn't suspect that would be a high resistance. It's more like high inspiratory effort bleeding into the expiratory time, which is why you cut off that little peak on your peak expiratory flow.
Yeah, no disagreement there. That's so that's why we highlighted here PMOS. So again, the key feature is PMOS, and then you have resistance. So that could be also a presence of resistance. I'm not saying a negative there. So we're aligned here. Perfect.
So, and the other thing to keep in mind is that most of the time when we talk about PMOS on inspiration, it's a positive PMOS, right? Now, a positive PMOS in volume control decreases the airway pressure, but it increases flow and volume on pressure control. But there's nothing to say PMOS can't be negative, right? An expiratory effort, or even a kind of a braking effort like you see in infants. And that's what's happening in 2. The expiratory is the PMOS, the load is an expiratory PMOS. It's still a load on the muscles, but it's just in the opposite direction that we typically see.
Rob, you're getting cut. If you want to re-log in.
Okay, let me go out.
All right.
Go back.
So what else connected to that already? So let's start by the patient ventilator discordance as we come back. And the first one that we look at is trigger. And remember, on this ventilator, the trigger, when the ventilator senses this to be a patient signal, doesn't mean that it's the patient. It just sends a trigger because it sends a signal that it interpreted as being the patient. It will change colors on the waveform. And so you can see here very nicely, I amplified it for you, that there is a change in color to white. The same on breath number 5, there's a color change. But in breath number 2 and breath number 4, there's actually no change in color, neither on the pressure waveform or on the flow waveform, which tells us that this is triggered by the machine. So what you have here, if in the first breath it's triggered by the patient, and the trigger seems to be what I would say essentially normal. If there's the negative deflection of the pressure, probably it's coming from another breath here, but we'll assume that it's a normal trigger. And then the breath continues. The second breath actually is triggered by the machine, right? So that's not a patient ventilator interactions. It's simply triggered by the machine, but there's no flow at all, and we'll talk about that. The third breath is triggered by the machine. The fourth breath is not triggered, it's triggered by the machine, sorry, patient machine. and again, patient. So patient, machine, and patient here. So when you look at this relationship in breath number, when we come back to breath number 2 and 3, you see that it's the machine followed by the patient. And that is a trigger pattern, or a pattern that we would call the machine triggered before the patient. Machine before patient tells you that the machine started earlier than the patient. Remember, the patient is the reference. So the machine started earlier in regards to the patient. And so this would be an early trigger, which we also call reverse trigger here. Now, sometimes in these machines, when there's very high resistance, you can have a false trigger triggering this, but there's many features, as Rob highlighted, that makes us think that this is that is the case. And I'm gonna erase for a second the screen so that we can point it out a little bit better. So I didn't press what I had to press, eraser here. So I'm gonna erase this for a second. And what you see is the following. So you see that this is the mandatory breath, it started. And then you see the breath ends, and the machine senses that there's patient effort. And you can see that the flow, there's definitely patient effort. This should be an exponential decay. So this goes with a patient effort trigger. We talked about this one too. Instead of looking like this, all of this is patient effort. All of this is patient effort. And on this one, the same thing. Actually, in this one, it's even more evident, the reverse trigger, because there's no flow, and then suddenly the flow starts increasing, which means that the patient is doing effort. And actually, you see the pressure drops because of the effort from the patient. And after that, it triggers the next breath, and you can see the continuity of the patient effort. So here, the effort from the patient starts here and ends here. Here, the effort from the patient starts here and ends around here. And on this one, the effort of the patient starts around here and finishes all the way over here. So questions, let me see what there is. So both triggers are early. Yes, Mike, that's correct. Rob, are you back?
I'm back. Can you hear me?
Yes, now I can hear you.
Good.
Very good. So we
what I said about PMUS.
Yes, the part that you were talking about, the presence of PMOS during expiration, but we have not gotten to that phase. So I was just going into the trigger.
Well, okay.
Do you want to talk about why there's no
just wait till we get the inspiration. That's fine.
Yeah. So if we got, I mean, that's the next phase is in inspiration. Do you want to talk about that? What's happening during the inspiration on the breath number 2 and breath number 4? Go ahead.
Yeah, well, we see that the flow goes to 0, even though the airway pressure rises above 0. What that means is the ventilator is trying to cause an inspiratory flow, but something is obstructing it. So either the patient is biting on the tube, or there's an obstruction, or more likely in this case, the patient is making a expiratory muscle effort. So during inspiration, you can have an inspiratory effort and you can have an expiratory effort. There's nothing stopping the patient from doing that. And it would appear that in this case, in 2 and 4, the patient's PMUS is just about as negative as the ventilator P positive is. So PMUS in the expiratory direction is negative.
You again. So
I'm sorry.
Increased by the expert. Rob, you're getting cut.
All right.
Yeah. So the PMOS is not letting the patient. So the patient is exhaling and actively exhaling, and the patient, the machine pressurizes, and they cannot, and then they can start the breath. So that's what's happening during this. So there's a fair amount of what we would call expiratory work. Are you there, Rob?
Yeah, can you hear me?
Yes. Now, an important thing just to highlight for everybody is that when you see a series of abnormalities on a waveform like this one. The one that you're gonna call is the reverse trigger, is the first one that you will find. Because if you treat this one, then you will solve all the other ones. So we know that reverse trigger will cause some amount of work shifting, and it will cause, like here, early cycling, like in this breath over here or on this one over here. But the treatment to fix the eye time, it's actually to fix reverse trigger. So question to the team would be, at this time, is now that you know that this patient is in pressure control with increased resistance, and what we see is a reverse trigger and active expiratory work, how would you deal with this? So there's a fair amount of people that said, well, drop the rate. I don't know what XD means. All righty. So yeah, somebody said, well, change the breath pattern to CSB. So let's see. So actually, Ariel, you took care of this patient, right? So I will show the next slide that actually shows what they did for this patient. And I will point out that what you guys said is right now the rate was set at 24. And now the rate was dropped to 15. But there was a change in mode. So it was changed to this mode that has a different tag, which is pressure control IMB2, and in this case is SS, and that just means that when there is enough spontaneous breaths that above and actually you can talk about this, Ari, then the mandatory breaths are suppressed, and so we continue to see the same pattern as we saw on the other one, in which the mandatory breath is not delivered, followed by the spontaneous breath, but now with smaller tidal volumes, but there still continues to be mandatory breath. So can you talk about what your research showed on here, Ari, please?
Yes. This patient was about to be heavily sedated, so I tried different modes, but I was concerned about safety, so I tried first auto mode to be sure that there is some safety backup. The problem with auto mode, and we are describing this on the white paper on the next paper that's going to be published on the respiratory care, is that the apnea time after 1 or 2 breaths is not the apnea time we saw on the vent, it's much shorter. In this case, it was triggering mandatory breaths way sooner than the patient wanted. So the mandatory breaths were delivered while the patient was still trying to force the air out. That's why, as Rob well explained, the P mask counterbalanced the P vent and created a zero pressure, so we don't see any flow differential created, any pressure differential created. Auto mode at that time, it wasn't an ideal mode, and even you can see that we decreased the rate from a previous 24 to 10, and still the patient wanted a lower respiratory rate.
Very good. So after that, so you can continue to see that this phenomenon. Did you try? And this is a common question. To do an expiratory pause and see if there was any PMOS during the expiratory pause, Ariel.
Yes, at a certain point, the total PIP was 15 on the rate of 24. Later on, at this present rate was maybe 10, but sometimes it was pretty impossible to measure it because the patient was still pushing the air out.
Okay. So then the patient was changed to pressure support, and just to see what the patient would do on their own, correct? And this is what you now see. on this circumstance is that the actual rate that the patient wanted to maintain was a rate of 8. And all the breaths are triggered by the patient, as you can see here. And now each breath that the patient takes, there's active inspiratory, the flow increases. Actually, there's a high amount of PMOS, and then after that comes the expiration. So it's patient's trigger and patient cycled with this minute ventilation that actually probably it's too low depending what you guys found. So you want to talk about that, Ari?
Eduardo, if you
He got cut.
the rate going off,
Well,
can you hear me?
it's cutting. Can you turn off your camera too, please?
Can you? We live in the same area.
Well, go ahead.
Okay, I don't find out. Okay.
All right, Ariel, let's just for the sake of time, let's just finish this. So in general, the overall message for the team is that there is we are still learning what early trigger or reverse trigger and how it's formed or where the problems come from it. There is one that has to do with entrainment of the respiratory rate, in which essentially the respiratory center signal starts matching the respiratory rate from the ventilator, and it follows that pathway. And there's another in which there is a kind of reflex activation of the muscles. And so the thought is that as the breath distends the lung and the chest wall, that activates signals from the nerves that activate a breath. So kind of just like a reflex when they do the reflex with a hammer in your knee, that something similar would happen on the chest wall. So this seems to be related to entrainment and very active expiratory phase on this patient. Unfortunately, the connection state is very poor today, and so we cannot hear a little bit better from Ariel. But we'll be sure when we post this on YouTube to put a comment on what the thoughts were and what was the management for the patient. With that, I will put here the CME for the CCF caregivers, which here's the code for all of you to use, and then the CRC for all the RTs. Remember, these will be posted on YouTube, and you can go through it, send us your comments or disagreements, as we usually do, to try to hear and get better at how we read waveforms. For the sake of everybody, just in summary, I know that there was a lot of connection issues. The summary of this waveform was, this is pressure control CMBS with a lot of inspiratory and expiratory PMOS. The breath was not being delivered because there was expiratory PMOS canceling essentially all the inspiratory pressure. And there was early trigger occurring in this patient, also called reverse trigger. And we didn't find the optimal rate until we placed the patient on pressure controlled CSB. And so meaning pressure support mode, which yielded a better synchronous waveform, but evidently the amount of gas exchange is to be determined if it's appropriate or not for the patient. With that, I want to thank you in name of Rob and Ari, which I know that they must be frustrated from the connectivity. If you have any other waveforms that you want to analyze, just put them on Twitter, either for Ariel or myself, and send us please, or you can send us comments to the emails here attached. With that, thank you very much, and have a great day.